Hello, everybody. This is Peter Ngan. I am professor and chair of the Department of Orthodontics, West Virginia University. I bring greetings from our department. We are the mountaineers. We like, hunting, shooting rifles, and we also like American football. This is our department team. We have 9 graduate students. If you ever get a chance to come to Morgantown, West Virginia, come and visit us. So I was asked to give a webinar for the paper or article published in the Asian Pacific Orthodontic Trend Journal. So I will be covering early, timely treatment of unerupted maxillary lateral incisors. Very few malocclusions can be prevented, but 25% can be intercepted. So if your practice has more than 10 to 15% that are early treatment, I think that you will be treating malocclusions too early. But there are a few of them, after my 36 years of practice, that I think it will be beneficial for your practice and your patients to treat them earlier. So obviously, the earlier you intercept a malocclusion, that there are more ways of treating these children because you have growth and also the eruption of teeth to help you along with the treatment. But I told my residents that the most important thing is that you set an objective for your early phase 1 treatment. If you do not have an objective, you will fall into the trap of much longer treatment and you don't know when to stop treatment. So one of the objectives is to remove the etiologic factor, prevent progressive, irreversible either soft tissue or bony damages. So you can consider increasing the arch length for unerupted incisors. Now, I mean maxillary incisors. Now, you may sometimes consider early treatment for correcting anterior or posterior crossbites. Now, there's another area that you might want to consider treating them early is to not prevent, but intercept future jaw discrepancy, especially the jaw discrepancy has to do with the maxilla because most of the growth in the maxilla, it's the maxillary sutural growth. So this morning, with a very short 25 minutes, I will cover increased arch length for unerupted maxillary lateral. So Donnay is a 7-year-old female. She has a nice profile, a slightly retrusive chin position. So if you take a look at the intraoral photograph, you will see that she has a blocked out maxillary lateral incisors. So there's not quite enough space for the eruption of maxillary lateral incisors. And if you take a look at the arch form of the maxillary arch compared to the mandibular arch, you will also see that she has a slightly tapered maxillary arch. So the diagnosis is unerupted maxillary lateral incisors. So the treatment strategy is to somehow gain space without proclining too much of her upper incisors. So maxillary expansion would be the good choice in this particular case, followed by 2x4 fixed appliance to align the incisors. And then obviously you will need some sort of a retention device to retain the width and also the alignment of the maxillary incisors after treatment. So I'm going to use a conventional fixed RPE or rapid palatal expansion to contrast with the contemporary bonded expansion appliance, because there are new materials that are available now, which is not 10 years ago, that makes a bonded expansion appliance easier to remove and also to insert. So let's take a look at the conventional way, okay, how we make a banded RPE. So the only difference in mixed dentition, I band the primary first molar instead of the primary second molar. And I usually use the premolar bands in my office. So you band the primary first molar and the permanent first molar. And then you go ahead and expand. And one of the advantages of bending the primary first molar is if you indeed need a coiled spring, you know, to close the diastema after the expansion, you can do that. And so you consolidate the maxillary incisors. Now, make sure that you don't start closing that diastema immediately after expansion. You're gonna, because it takes about 3 months for the bone to deposit. So basically you move from a nine-tie wire, like a 014 nine-tie, and then the next month 018 nine-tie. And then when you get to 018 stainless steel, then you can go ahead and consolidate the upper incisors. So it should not take you more than 6 months or maybe 7 months, okay, to expand and align the maxillary incisors. You can see the lower posterior teeth are actually lingually tipped, okay, but that's good because it's going to retain the maxillary arch. So let the lower posterior, if they want to, they can upright by itself. So you don't really need treatment on the lower arch. Now, for some of you, you know, who have noticed earlier that her lower incisors are also a little bit crowded, but I do not treat the lower incisors in the mixed dentition because I know that when the patients have the full permanent teeth, I will have to retreat this patient with full mouth braces. That's when I usually line or take care of the crowding in the lower arch. And most of us know that there is something called secondary spacing. So that means the lower incisors, because of the tongue pressure, is going to push the lower incisors forward, and you're going to gain a little bit of intercanine width in the lower arch. So here's the patients before and after treatment. So one of the nice fringe benefit that you're going to gain is that not only that you align the incisors, the patient also have a nice school pictures as far as the mom is concerned. So now I'm going to contrast with the contemporary bonded expander. So this is something that you can take home to your practice if you want to make it easy in-house bonded RPE for certain type of cases. No, so EK is an 8-year-old male, all right? Now he also have a slightly retrusive chin position, but as you already noticed that I do not address the jaw positions, especially if it has to do with mandibular growth. I don't tackle them in the mixed dentition. I tackle them when the patient is growing through the growth spurt. So the chief concern about EK is not that he's got to block out maxillary lateral incisors, it's got a protruded upper incisors. So you can notice that, you know, patient actually has a lip protuberance and also lip incompetency. So that's the indication for the treatment over here. Well, he doesn't have any block out teeth or any missing teeth. So the diagnosis is protruded maxillary incisors and lip incompetence. So the strategy is the same: maxillary expansion, 2x4 fixed appliance to align and retract the incisors followed by retainer. So notice the protruded maxillary incisors on the lateral cephalogram. So in this particular case, I elected to use a bonded expansion appliance because the patient has a relatively better oral hygiene. All right, that's important. When you use a bonded expansion appliance, the patient has to somehow clean around so you can see a little bit of food actually trapped next to the jack screw of the bonded inside RPE for that reason. Now, I'm going to let you know how to fabricate a bonded RPE using contemporary bonding materials in the next patient. Okay, so bear with me just for a second. Now, after you bonded the expansion appliance, if you want to, it's just like the conventional banded appliance, you can bond a bracket on the bonded expansion appliance. So the materials that you're going to use is a plastic conditioner and also something that we use for the aligners or clear aligners is called bond aligner. Okay, it's aligner adhesive. All right, so the plastic conditioner and the aligner adhesive. Now, some of these materials, if you forgot where and what's the name of it, go back to the Asian Pacific Orthodontic Journal, because this paper was published and the methodology was published in the APOS journal, the current issue. Okay, so go ahead, after you finish the expansion, you can go ahead align the incisors. So let's take a look at this patient. All right, this patient's, okay, we're going to, after expansions, align the upper incisors. All right, and you go through the same 3 wires, 014 night tie, 018 night tie, and the 3rd month. When you have 018 stainless steel, you can go ahead and consolidate the upper incisors. Okay, so here is the upper incisors, leveled and then retracted. Okay, and also consolidated. All right, so here is the patient after treatment. All right, now notice that this patient also has a kind of like an early exfoliation of lower primary canine. Again, I don't address that midline issues at this point of time. I'm going to wait until when the patient exfoliate the primary molars. At that time, I'm going to pay attention to the arch length in the lower arch. Okay, so this is after treatment. Now notice the lip competence and also retraction of the upper incisors. That was the objective of treatment of this patient. All right, so take a look at the inclination of the upper incisors before and after treatment. Now, this is the time that you're going to take notes on the fabrication of a bonded RPE. All right, so I'm going to use Athena, okay, as an example, because Athena is 10 years old. Now, she has a little bit more severe problem because not only the maxillary laterals are blocked out, they're also quite palatal. All right, so but the treatment is not different. Okay, it's still that she has a slightly taper upper arch. All right, so in that case, I will go ahead and use the same strategy. All right, because there's no other skeletal or any other dental abnormalities I can see in here. So I'll go ahead and fabricate her maxillary bonded expansion appliance. Okay, step number 1. The placement of the jack screw. Okay, so the jack screw should extend forward, all right, into the primary first molar area. All right, supported a little bit, by the little a bit of materials, to kind of stabilize the jack screw. And then you're going to go ahead and put separator solution. Okay, and basically because when you set down, you don't want the biocryl to kind of get stuck, to the models. All right. Then you're going to use the material called biocryl. All right. Now it's 125 millimeter in terms of the whole area of the material, and it's 2 millimeter thick. All right. So when you order this material, remember 125 millimeters, 2 millimeter thick. all right? And you're gonna somehow have to allow the jack screw, the extension arm, to be able to attach to the bioacrylic material. So you're gonna add a little bit of a monomers, or some people call it, powder and liquid. Okay, so you're gonna mix it up a little bit like that kind of consistency right here. All right, and then you're gonna go ahead and put it on between the arm and the teeth. All right, so after that, then you're gonna go ahead and suck down with the for the bioacrylic material using whatever machine that you have, such as a mini star. By the way, I have no interest financially in any of the companies or materials that I present to you, because I just want to give you an example of one company or brand that you can purchase the materials to make this appliance. So after the suck down, then you have this remove the excess material. So you're going to first make an initial cut. Okay, notice the burr that I use, for the cut. All right, and then followed by a second cut right here. And then eventually, you're going to be separating, the appliance from the stone, and then polish it, with a brush, or a tapered, steel bird, for the lingual part of it. Okay, so here is the appliance made. All right, and then the next thing is you're going to go ahead and cement, the appliance to the patient, and that would be just the normal resin that you use for large composite. All right, so you bond that, on the patients, and then the next thing obviously you need to do is, okay, you go ahead and bond that bracket, on the appliance, which what I show you on the last patient. Now then you can go ahead and align the incisors by extracting the primary lateral incisors. All right, so after expansion, all right, now notice that, the bonded RP also have the advantage of if the patient has some sort of a deep overbite, things like that, it would disocclude the anterior teeth, for that reason, especially in case of a class 3 situation. All right, now, so you could go ahead and consolidate the incisors, okay, and that should not take more than 6 months, the whole process. Then finally, then you can notice one big advantage of using this contemporary fabrication of a bonded RPE. It's the ease of removing the appliance. All right, so here I am showing you one plier that can use to debond the appliance, and it really does not take much of a hassle, because this material, the bioacrylic, is much more friendly than the acrylic that are used in good old days for the bonded RPE. So go ahead and remove it. All right, so here is the patient's. Now notice the width of the upper arch. Okay, now it match with the ovoid width for the lower arch. All right, so here's the post-treatment photograph, so the patient looks better with the permanent lateral incisors in place. Okay, and the upper incisors are not proclined, okay, because we expanded the arch to accommodate the lateral incisors. So in summary, here I am, presenting you in contrast, using a contemporary way of fabricating a bonded RPE that you can use in your mixed dentition, okay? And you will like it after you make one of them in-house, because it's easy to make and it's also easy to remove in the patient's mouth. Okay, so I hope you will enjoy that in your practice. So if you have any question, you can either read the article that published in the APOS journal or send me an email. By the way, if it works in the office, send me an email, because for most teachers, the most gratifying part is to find out that it works after you show somebody how it can be done. So good luck. Okay, thank you for attending my webinar. Bye-bye.